Thank you. Uh, Good evening, all. We are starting with our session 2 of this exam-oriented webinars. This is an VR Spine Learnings initiative, and this was planned in a way that it will help our ASSI and FNB fellows who are appearing for exams. So we're going to have 10 sessions with 5 long cases, 5 short cases, a 3-series lecture series of scoliosis, and some table discussions in the end. We have our first session was on cervical myelopathy long case, and we had an esteemed faculty. And so as for today, we are having a very esteemed faculty with Dr. K.V. Menon, who is well known for his work in scoliosis, AO, and he's one of the founders for AO Scoli Week, which is very popular in for the pediatric deformity courses in India. His work on shoulder balance is also very well recognized. We have Ranjit Unnikishan sir. He's at Trivandrum. He has just presented a wonderful case for us. He's getting all these nasty scoliosis, and we hope to hear from you again and again. We'll be joined by Kshiti Chaudhary sir in some time. He's working at PD Hinduja Hospital, Mumbai, a very academic person, and it will be a great discussion to have. It'll be great to have him here for the discussion. And we have Abhay sir, Dr. Abhay Nene, my mentor and my guide here. Today, the case is being presented by Dr. Umesh Kanade. He's doing his ASI fellowship at Apollo, Chennai, under Dr. Sajan Hegde sir, and he'll be the exam going fellow. So today's format is going to be, he'll be presenting a case, and we have 4 examiners in front of us, and they'll be asking him questions, and we can raise our doubts as and when required. Over to you, Umesh.
So before that, Umesh, I'll just come in. Harshal, thanks for that introduction and setting this up for all of us. The format of this is that we are going to be stopping the presenter as often as we can. The idea is to get in as many questions in. So it's not a one-way street, and there's no, formality in waiting for him to finish presentation. We are just going to be attacking him throughout. And that's what's going to help him, build up his, his talks for the exam. So examiners, Dr. Menon. Yes, Dr. Menon.
So what is the procedure for stopping the person? You just raise your hands?
You just you're the examiner. You can just butt in. If anyone else who's a non-examiner wants to talk, should raise their hands. But Unni, Kshitij, you, me, Harshal, we all have the right to just butt in straight away.
Okay.
Umesh, you can share your screen, please.
Yes, sir. Yes, sir.
Oh, Kshitij sir also here.
Yeah, Kshitij is here.
You can start, Umesh.
Yeah. 1 minute, sir. It is. Sir, I'm not seeing my screen. I'm seeing the participant's name here.
We can actually see your screen.
Okay.
Harshal, you're muted. Harshal, you're muted.
Is it visible, sir, now?
Yes, for us it is visible.
Yeah. Okay. A very good evening to all my teachers, seniors, and colleagues. I'm Dr. Umesh Kanade. I'm presenting a long case today.
Can you make it full screen?
Yeah, it is full screen, sir. It is full screen from my side, sir.
Okay, go ahead.
Umesh,
Yes,
please
sir.
make it presentation mode. It is like not in a presentation mode, please.
Sir, it is in a presentation mode from my side.
No, it is not. It is not from here, whatever we see.
So what he has to do, he has to stop sharing and reshare it. It will not come.
Okay, sir.
Yeah, stop sharing and reshare it.
Okay, sir.
Harshal, you're muted.
Umesh, you want me to share your PPT? I have a PPT.
No.
Yeah.
Shared now. Is it visible, sir?
Yes. Try to make it full screen and start.
Not full screen.
Is it full screen now?
Yeah.
Yes.
Yeah.
Very good evening to all my teachers, seniors, and colleagues. I'm Dr. Umesh Kanade, presenting a long case today. The patient is a 16-year-old girl presented with concerns of shape of her back and uneven shoulders since last 3 years. History of presenting illness. Patient was apparently all right 3 years back. Parents noticed the deformity of the back. Initially, to start with, the deformity was mild, but gradually progressed to the present state. The deformity was coinciding with the increase in the height of the patient, and the deformity becomes more prominent on bending forwards. There is no history of pain associated with the deformity, no history of weakness or neurodeficit, no history of bladder bowel disturbances. There is no history of any discolored patches over body or the discolored patches in our siblings, no history of any vision defects or hearing defects, no history of trauma. Gives negative history of low-grade fever and weight loss, and no history of dyspnea on exertion and recurrent chest infection, no history of other deformities like urogenital anomalies and limb deformities, no history of similar complaints in the parents or siblings. Currently, the deformity is not affecting her activities of daily living, except the concern of shape of her back and asymmetry of the shoulders.
Umesh, why did you ask for a similar complaint in parents or siblings?
Because it has a maternal genetic aspect to the scoliosis.
What scoliosis as a maternal genetic aspect? Can you be more clear?
The idiopathic scoliosis, it has a genetic aspect.
Which gene is responsible?
You mean family history or genetic association? What is the difference you want to tell? Make it clear here.
A family history, sir.
Family history. Family history does not mean it is genetic.
Right? Yes, sir.
So what difference it makes if somebody in the family had a spinal deformity in this child?
If someone has a spinal deformity, then we have to screen other family members also regarding the deformity, sir. They may have.
If this child has a deformity, you will screen other family siblings for a spinal deformity. The question is, if somebody else in the family had a deformity, what is the implication of that in the treatment or in the prognosis of this child?
So if the child is presenting with any such deformity kind of symptoms, then we'll think more inclined towards the family history aspects.
No. The question which I want to ask is that, does having a family history of scoliosis bear any indication or any indicator in the progression or the natural history of this child's spinal deformity?
Yes, sir. The progress, they can have a rapid progression of the deformity, sir.
Okay. So basically what sir is trying to ask you is, if you have a family history, then how would your thought process will change with regards to etiology, the progression, the treatment, and also what other things you will check in etiology to get other etiologies available for this child?
If we have a family history, then we can think of rapid progression and severe deformities and any other deformities in the child. And atypical, we can screen for atypical.
Why do you say that, Umesh? Why are you saying that if there's a family history, there's likely to be a rapid progression? Have you read it somewhere that someone with a family history gets a rapid progression?
I have read it read it across somewhere in books, sir.
And you believe it?
So KV sir has got a standard. He has got a good talk at this. So the thing is, so I tell doctor, what are my chances of having scoliosis in my family if my grandmother had scoliosis?
Percentage wise, I don't know, sir.
So the risk is 6 times higher, as per the that series, right? As per the series, 6 times higher chance of having a significant curve in a family if somebody in the family had a spinal deformity which needed treatment, not any deformity, which needed treatment.
Yes, sir.
Okay.
Sir, I just want to come in here. Sir, Ranjit, sir, this is regards to idiopathic scoliosis?
Purely idiopathic scoliosis. Purely idiopathic. Not, and the two adolescent idiopathics, not in juveniles, not in early onsets.
Got it.
So, Umesh, you kind of walked into a trap right now. We were trying to corner you, and with less confident knowledge, you were trying to make your way out. So sometimes it's easier to say, actually, I'm not aware of this, and I've taken this as a routine history. If you don't know,
Yes,
number one. Number two is that if the examiner is getting aggressive with one point, you know that guy wants you to say this, is sometimes a good idea to back off and say, maybe sir, I think what you're saying is correct, and then move on, rather than stick to your point unless you're absolutely sure. It's different if you're absolutely sure, because sometimes it could be a double bluff, but then you should be sure. Yes, but you right now actually walked in two traps, and that is not okay, because then I'm left with an impression that you don't know anything also, and you're being obstinate also. Like it's a double whammy. So you got to learn to bail out from this one in the real life situation. All right, go ahead.
And why did you ask about pain, Umesh?
So mostly the idiopathic scoliosis usually doesn't have pain. The pain, there are some causes of painful scoliosis. I wanted to rule out the other causes which has a painful scoliosis.
Can you name few?
What scoliosis has pain?
Yes, sir. Pardon.
What scoliosis has pain?
So the scoliosis associated with osteoid osteoma, and if the scoliosis associated with spondylolisthesis, they have associated pain, sir.
So what percentage of adolescent idiopathic scoliosis will have pain?
And
percentage wise, I don't know, sir. But
why
usually,
will they have pain? If they have pain, why will they have pain?
Because of the listhesis, if they develop listhesis, they may have pain, sir.
So that's a lumbosacral junctional pain, not the pain along the curve. Who has pain?
Yes, sir. And due to muscular fatigue, also they can have pain, and the area of the rib hump and all those.
Area of rib hump pain? No, it's mostly this muscular pain because of fatigue.
Yes,
the standard history. I have a deformity. I have nothing. I can do everything. But when I stand for a while, my back aches. I have to sit down. I get better. Again, I can stand for a while. Again, my back aches. I sit down. That is a history.
Yes, sir.
Let's go ahead.
Birth and developmental history. Patient is second body in order and born of a non-consanguineous marriage. She is born of full-term normal vaginal delivery with no history of NICU stay. Normal developmental milestones. Immunized as per she is immunized as per schedule, and the patient attained menarche 3 years back. There is no history of similar complaints in the parents coming to family history. Coming to general physical examination.
No, stop. Come back to your history again. Yeah. So again, what is the importance of developmental milestones? Why did you ask it?
So delayed developmental milestones. I wanted to rule out other causes of scoliosis that has delayed developmental milestones.
For example.
Neuromuscular scoliosis associated with neurofibromatosis also.
In history, you said the child is 16 years old.
Yes, sir.
And the child noticed the deformity since 3 years of age, since 3 years ago.
Yes, sir.
And it has progressed over time.
Yes, sir.
You also said that the child attained menarche 3 years back.
Yes, sir.
Right? So that means after menarche, the curve has progressed.
They have noticed, yes, sir.
And it has progressed. You told it is worsening over last 3 years' time. Right?
Yes, sir.
Now, with, see, the scoliosis diagnosis is straightforward. It is deformity, you see it. Now, the entire thing of taking history and evaluating is to predict the history of progression and to decide to treat, not to treat. By based on your understanding of adolescent idiopathic scoliosis, after a child has attained menarche, how long will the child grow? Significant growth.
It won't progress significantly after the menarche, sir.
So, but this child has progressed after menarche as per history. It was she's 16. At 13 years of age, she got menarche. At 13 years of age, then deformity is noticed, but it progressed significantly in 3 years. Does it fit into the picture? Or then when you see this picture, what do you think extra?
So they have noticed it at 3 years, before 3 years, but it would have been started before that, sir. And then it has progressed, sir.
Yeah. So generally, how long does the child grow after the child has achieved menarche?
So 2 years after menarche, they can grow, sir.
So roughly 1 year, 1 year,
Yes,
1 year plus or minus 6 months. So that's why the significant growth happens after menarche, right? So then, so why does the curve progress? What are the reasons for, if you are seeing there's a curve and it's progress, why does the curve progress in scoliosis?
Due to increase in the longitudinal growth height of the patient.
So one is growth, and what else? Is growth the only driver for deformity, or something else is also there? Why it might increase? This is what we get from the history when you think, when you get to history. So keep it in mind. We should know, why does the curve progress? Because we are trying to define the natural history. At 16, you saw the child. They saw it at 3 years of age. Child was already post-menarchal when the deformity was noticed, but the curve progressed. Right? Okay. Menon sir, anything? Abhay, anything to ask more?
Any mechanical causes you can think of?
That's exactly what I'm trying to ask. Yeah. So you should think there is something more than growth, what is happening there. Right? So what is that thing which is more than growth, which will lead to deformity progression?
Asymmetric growth of the spine leading
that is all
to
growth. That all come under the heading of growth. So what is there other than growth which will drive the deformity? So ask the question, mechanical causes. So what exactly you think is there?
The asymmetric wedging of the disc also can cause the deformity progression, sir.
No. So it all comes under a single thing, Hooter-Fachman's principle. We all think about growth.
Yeah, there is. Yes.
So what is the Hooter-Fachman's law that you're talking about?
In Hooter-Fachman's law, sir, if the one side of the curvature, we arrest the growth on the one side of the curvature, the other side grows, sir.
That's not what Hooter-Fachman's law says.
Yes.
What does the law say? It talks about mechanical impact on growth.
Yes, sir. Mechanically modulated endochondral growth.
Correct. So what about it? So just tell us, just explain what happens. The mechanically modulated growth.
Spine is there is asymmetric growth of the anterior and posterior column of the spine. Sorry, sir.
Just tell us about the Hooter-Fachman's law.
Hooter-Fachman law says there is mechanical modulated endochondral growth of the.
Explain it.
Yes, sir.
What is the mechanical modulation?
Mechanical modulation is that if one side of the curvature is fixed, the other side grows, sir.
Mechanical has to be something with load.
Yes, I think
loading. Yes, sir. Unloading of the spine on one side, the growth, asymmetric growth.
All that it says is, if you compress an endochondral growth plate, it will slow down the growth, and if you apply tensile force on it, it will accelerate the growth. That's all the Hooter-Fachman law says. And what you are explaining is how it is applicable to the spinal deformity. If you compress a growth plate, it will slow down the growth, and if you distract a growth plate, it will accelerate the growth. That's what Hooter-Fachman law says. Okay.
Yes.
So basically, it is the growth, and second is the deformity itself. The quantum of deformity decides the mechanical loading in that case. So that is why we say after X amount of degree, we have to suggest surgery, or after X amount we have to brace, because that is the property of the curve itself. So the two driver is, one is the growth, second is the curve angle or the drive or the amount of deformity itself, right? That both itself says that is why we speak about Euler's law, right? Euler's law, we all speak about Euler's law of beam and all that, right? That all says how a deformity itself can drive the deformity.
Yes.
Right? That's why we have to have that history. So in this case, growth is not much of an event here, because 3 years back was menarche. The child is now progression. So I think in my mind, before I see the patient or the X-ray, that the deformity is significant because it is progressive.
Yes,
that is what the info I got from what you told.
Yes, sir.
Can I also ask you another question? What is the peak height velocity got to do with the child's menarche?
So usually the peak height velocity coincides 6 months before the menarche, sir. It starts 6 months before menarche.
And what does it have to do with the deformity?
So the deformity has a rapid progression during that period, sir.
So actually, though the parents noticed this deformity 3 years back, probably the rapid growth occurred 6 months before the parents.
Yes, sir.
Correct?
Yes, sir.
Okay.
So again, one more point. You have taken any treatment history in last 3 years? Anything? Is it important here?
Yes, sir. It is important. They are first consulted to us.
So in last 3 years, have they tried any other form of treatment when they notice deformity or anything? Does that have any relevance with the treatment?
They have noticed the deformity, but they have not sought any medical attention before this.
Okay. Fine. So your history ends here. So what is your provisional diagnosis right now?
So on the basis of history, it is a case of a spinal deformity in a 16-year-old girl, 3 years post-menarchal. The curve which is progressive and coinciding with the increasing height of the patient, with no obvious positive factors on the basis of history, and no obvious factors suggestive of complications associated with the deformity.
Is there anything to add in the history?
I would be keen for you to tell us which part of the deformity bothers her. Like, I would like you to finish this history by saying that, so she's come to us with a complaint of a cosmetic,
chief functional disability of issue. Yeah, chief complaint of cosmetic issue. And just to complete, to add to Abhay's question, he asked a question to you: is there any genetic background? Right? What is genetics to do with this thing? So there is one FBN1 gene which was actually shown more in Marfan's, but also has been found to be in people with adolescent scoliosis, who, if present, it is just what you call, Bejagiri, who are known to have fast progression. FBN1, right? Because theory, something you should blutter when you ask. So that is FBN1 but it is more common in Marfan's, but it's been seen with people also with adolescent scoliosis who have got fast progression. Nobody does it. It is just for theoretical knowledge.
Yes, sir. Can I proceed, sir?
Yeah.
On general physical examination, patient is conscious, cooperative, and well-oriented in time, place, and person. There is no evidence of pallor, clubbing, and cyanosis. Vitals are stable. Weight is 43 kg, and standing height is 145 centimeter, and sitting height is 70 centimeter. Other systemic examination: respiratory system, cardiovascular system, and per abdomen normal, sir.
Please stop for a second. Why did you do the standing height and the sitting height?
So we do standing height and sitting height, and on serial measurements, if the sitting height is not increasing and the curve is progressing, we have to suggest a treatment, sir.
So are you suggesting that the indication, or at least one of the indications for treatment, is failure of the sitting height to improve?
And we have to rule out the other causes also by calculating the upper segment and lower segment ratio, sir.
So where did you read this, that sitting height failure to improve has got any bearing on the treatment? If that forms an indication of treatment, as you said. Do you have any evidence for that, or have you read it somewhere, or can you quote that?
I've
Or
read it, sir,
rather,
but
why do you monitor sitting height? Why do you document sitting height? Sitting height is truncal height, is spinal height, right?
yes, sir.
Because it is suprapelvic cause length you're measuring. So what exactly has to do with sitting height and your decision to treat?
If on sitting height is not increasing, it means the spinal curvature is increasing more.
So what is the ratio between
Lateral? Yes.
What is the ratio between the sitting height and the standing height in a normal child?
Normal child, the ratio should be around should be 1, sir.
So at what stage you think that it is abnormal?
If it is less than 0.85, it is abnormal, sir. We suggest we should think of other factors.
What other factors?
And
So
Marfan syndrome, one of the diagnostic criteria, sir, says the upper segment, lower segment ratio less than 0.85.
But we
Is
are
there any other anthropometric measure that you would do?
Sorry, sir, I couldn't.
Any other anthropometric measurement that you would like to do for these children?
It is coming in the next slide, sir. Arm span also.
So it has to come before systemic examination.
That's
because
right.
here, all of us thought you missed that.
Yeah, when you committed that, we thought you omitted the other one.
No, it's coming soon.
So
Okay.
can I comment on your history? Sorry, I've been listening.
Yeah, welcome and please.
Hi, sorry, I was in and out. I mean, his history was quite good, I thought. But one of my pet peeves in these like history presentations by students is that they just go on and on about negative history. I don't know. I mean, I heard that part of it, but there is no end to that negative history in scoliosis, especially in idiopathic scoliosis, right? So, and if you go to that page of yours, you are asking for no history of patches and I don't know, discolored patches and this and that. Like these are all examination findings, right? If there are discolored patches, you will find them on the examination. It's not a history that you take off. History is of complaints, is what patients complain of, right? So there'll be some complaints that are associated with deformity is what you are looking for in your history presentation. You can't literally rule out any of the etiological causes on an history. So whereas you're talking about weakness and all those things are fine, but it goes on rambling for a very, very long time. When you talk about like the deformity was insidious in onset, it means that it was not associated with trauma. You know what I mean?
Yes.
That you don't have to kind of go around and round about it. And what Herschel said was more important for you to describe treatment history at this point in time. And coming to the general examination, at least I prefer, and at least how I presented during my time was to get to this spine examination first, because general examination in deformity is extremely long and it's like it doesn't end. It is like a head to toe examination of the all the musculoskeletal system. So what tends to happen in the exam with a general examination in scoliosis is that you just keep on going on and on and on about it before getting to the scoliosis. You know what I mean?
Yes, sir.
But
So
I would like to mention,
uh-huh.
I would like to mention here, can you hear me?
Yeah, very well.
Yes, sir.
I guess it is damned if you do, damned if you don't.
Yeah.
As far as examinee is concerned, he doesn't know what. I fully agree with you that he should quickly.
So I have a solution. I have a solution for it, which I used in my exam. So the solution is that you say that you would say the general examination at the end of the exam. You start off only like that. That I would like to describe my general examination at the end of spine examination. If your examiner interrupts you and says that no, I want to hear the whole thing now, well, you give it to him, right? And that way, what happens is that you have a much smoother flow. the examiner has a mental image of the patient's deformity in the mind before you are talking about sitting height and arm span and, arachnodactyly and high arch palate and all those sort of things, you know what I mean? You give the choice to the examiner that I would like to describe my general examination at the end. And if they say, okay, then it's fine. If they say, no, I want to hear it, then you go from the tip of his head to the, bottom of his toe. So that would be the entire general examination is what I used to do in the exam.
I think Kshitij, you got it spot on. It's important for you to drag the examiner and the discussion to the area of your strength. And clearly the area of your strength is not respiratory system or, high arch palate. It is about how you describe the curve. So it would be a good idea, I think, as a general take home that you say, I would like to describe the examination of the spine first and start talking. And it's very, very unlikely that in an ASSI exam, your examiners are spine surgeons. They're going to love talking about the scoliosis, and you all will be both on an area which is of comfort to both of you.
I agree. Yeah. I mean, getting into a discussion about clubbing and sitting height is not something that you would want. You have to lead the examiner into the clinic, into the presentation, not give them, clues to ask you about criteria for Marfan's and all. Because really the general examination in scoliosis is humongous. You cannot end it. There's no end to it. The examiner will always feel that you have missed out on something. That's what
Very
happens.
true, sir.
Let's come to the arm span. What did you say about the arm span? You moved to the arm span, right? Next,
yes,
142. And what was the height of the child?
Height was 145 centimeters.
So what does this tell you? If the height is 145 and the arm span is 142, is there any inference there for you?
Yes, sir. If the arm span to height ratio is more than 1.05, it's abnormal, sir.
So
it rules out the other causes of scoliosis.
So
rather than rules out, it also tells you about the severity of the present deformity.
Yes, sir.
So what is a normal arm span to height ratio? Like a non-scoliotic person, what's his normal ratio?
It should be 1, sir, or
1:1. Yeah.
Yes.
Right. So here you have a height that's more than the arm span.
Yes, sir.
So is that in keeping with a scoliotic child?
No, sir.
Yes or no?
No, sir.
So any reason why that might be happening here?
Because of deformity, sir.
What do you expect because of deformity? The height to be less than the arm span, isn't it?
Yes, sir.
So, I mean, even I'm finding it a bit weird. I don't know the
No, I mean, the way to look at it is that, you have a range. It's not one. The ratio is not one, like exact one, right? There's going to be variations in people. So a small amount of variation is acceptable. There's going to be a threshold after which you cross. But there's one more important reason why you are doing arm span. It's not just for Marfan's.
Yes, sir.
It's a very common test later on, which will use arm span in their assessment for most scoliosis patients. What is that test? It's the PFT.
Oh, yes, sir.
Why would they use arm span in PFT?
Umesh, this is a standard question and it is a standard answer. No excuses for not knowing this one.
So see how it gets into a discussion that goes in a very different direction. You would want to get to the scoliosis and you are like, examiners will pick on all these small points.
Having said that, this is a standard question. This is not out of
line. It's true.
Because PFT and scoliosis, there's a inherent link that goes on. PFT is always quoted in reference to the height of the child, isn't it?
So the height cannot be measured accurately with a scoliosis, right? So percentage predicted values are going to be different. So the percentage predicted values in PFT will correspond to the arm span. That's how you get the percentage predicted values.
Yes.
And for that, you should know how to read a PFT. So I think we'll get to that later. But just remember that arm span, that's one more place where you would have the use of arm span, right?
Yes. Yes.
Go ahead.
There is no limb-length discrepancy, sir. Bilateral foot size is equal and calf muscles are equal. No evidence of ligamentous laxity and marfanoid feature. Chest expansion is 4.5 centimeter and single breath count is 35, sir.
So can I suggest one method of presenting general examination in scoliosis?
Yes, sir, please, sir.
I mean, the way to present it is go from head to toe. Don't make the examiner jump from neck to the leg to back to the chest to back to, just don't go back and forth too much. You start from the head. There are no dysmorphic features, hairline, ears, torticollis. Things go down till the foot. There are no foot anomalies and all equal and all those things, right? You are going in one from, so the examiner knows that you have a systematic way of looking at general examination in a scoliosis patient. You're not jumping from one place to the other. You know what I mean? So that way it would be also easy for the examiner to follow, but it also would be easy for you to not miss on any gross thing in the general examination.
Sir, in the inspection, I have mentioned it, sir, in a particular order.
Right.
I guess that,
no,
sir,
about
he's
like
stuck
a
between
general
those.
Yeah, it's not. I'm not talking about spine examination.
Yeah.
Yes, sir.
Okay. I'm
Yes,
talking
sir.
about everything other than spine examination.
Yes, sir.
It's a general examination, right? So going from, the faces to the high arch palate to the ears to the web neck and torticollis and, sprangle shoulders and, so many things you are looking from top to bottom other than the spine.
Yes, sir.
Yes.
That is the general examination in scoliosis. Like, you can have a patient with scoliosis and have radioulnar synostosis.
Yes.
But so you will have to do something systematically. You don't have to say negative to every small thing. You can say that the musculoskeletal examination is normal, but it's like, follow a more systematic pattern from head to toe.
Yes, sir.
Please tell us how you examined for ligamentous laxity.
So I examined ligamentous laxity according to the Baton's score, sir.
What is the score you got in this patient?
To rule out
No,
other.
what is the Baton score you got in this patient? You said you examined according to Baton.
Yes,
so
sir.
what is the Baton score that you got?
That is to see, do you know the score?
Yes, sir.
That's
the score is more than 5/9 is an abnormal, sir. She is not having any ligamentous laxity, sir.
So you got 0.
the question is, what was the score in your patient? That's what Kev is asking.
You said you did a Baton score for ligamentous laxity, no?
Yes, sir.
So what was the score you got?
She is not having any ligamentous laxity, sir. So not scored.
Okay. So let's pass over that and go on to the next.
What is the significance of foot size? Why did you check for foot size?
Unequal foot size, if it is there, we should look for any intraspinal that is suggestive of any intraspinal anomalies.
Okay. Fine. Carry on.
I examined patient in standing sitting from front, back, and sides in front of a female attendant. The patient is walking with a bipedal unassisted gait, having alternating and rhythmic stance and swing phases with a normal base. On inspection from the back, head centered over shoulders, hairline at a normal level, sir. Right shoulder appears at elevated as compared to the left with fullness of the right trapezius. prominence and elevation of the right scapula. Left side chest arm distance increased. There is a smooth curvature of the spine in thoracic and thoracolumbar region with thoracic curve convexity on the right side and thoracolumbar lumbar curve convexity on the left side. Right side rib hump presents, sir. Prominence of the flank crease on the right, truncal shift present on the right side. Skin over the back is normal. There is no tuft of hair, midline cystic swelling, discolored patches. Both PSIs are at the same levels.
Do you think this is kyphoscoliosis?
No, sir.
Why?
On sagittal, on examination from the side, sir, I cannot accurately delineate the kyphosis exactly whether it is hyperkyphosis.
But doesn't she look bent over? Can't you see that bend in the thoracic spine?
He's pushing you to something, so try to understand that.
Because of the rib hump, there is a this is the pictures.
Right. So then, how would you make out that this is a rib hump related pseudokyphosis and not a true kyphosis?
We do a forward bending, Adams forward bending test to make the rib hump more prominent, sir. And there should be the kyphosis should be visible more on the Adams forward bending.
If you have someone with Schurman's kyphosis, will that also not get more prominent on forward bending?
So that will have a uniform kyphosis, sir, without any paraspinal region prominence.
So can you say that again? How do you differentiate that this is not a kyphosis by forward bending test? By forward bending, what's your inference? If the kyphosis increases or if the rib hump is more prominent, does that suggest that she doesn't have a kyphosis?
We have to examine her more on the from the side, sir, on a sagittal view to a certain exaggerated kyphosis.
Yeah, what I'm looking for is you got to actually, palpate the spinal processes using your thumb.
Yeah.
And you'll see them actually going deep in, and then because even on the sagittal examination, you will still see a exaggerated kyphosis.
It is on palpation.
Umesh, the way you want to answer, like examiners will ask question at inspection or palpation or any time. So you can tell them that, sir, I am not able to make out the kyphosis on inspection. I would like to confirm my findings on palpation.
Yes,
that way.
I have done it in palpation.
Head centered over shoulder, truncal shift to the right side. Are they going together?
Or rather, in another way, can you comment about her balance? Overall truncal balance.
Truncal balance.
Looking at her.
And how do you measure truncal balance?
Clinically.
Look at her. Is she balanced or not?
Yes, sir, she is balanced because head is.
How do you determine that? How do you determine that she is balanced?
In subsequent examinations, sir, on.
No. On this
from this exam, just look at this. Just look at the patient.
The neck is not tilted off-centered, sir. It is centered over the pelvis.
Balance is neck shift or neck tilt?
No, sir. Head centered over the pelvis, shoulder and pelvis is the coronal balance.
So, what is the parameter that you're going to measure on this girl, on this picture that you see?
We should pass a plumb line, sir. If the plumb lines falls in the gluteal cleft, natal cleft, then it is a coronal balance.
Occiput to sacrum.
Yes, sir.
Plumb line drop from occiput to sacrum should lie within an inch of the gluteal cleft.
Gluteal cleft.
Okay.
So, Umesh, what is expected out of a spine fellow's presentation is not to compartmentalize into inspection and palpation. You have examined this patient for half an hour and then you are presenting, right? So you know what is going to follow. So if a question is asked, you can't be like acting that I don't know what is going to follow. You have already seen this patient completely.
Yes.
Correct? So even though you have not gotten to palpation or whatever, it doesn't mean you can answer that question because you have not presented it. It is not like that. So get out of the mindset of MS or orthopedic resident who presents versus a spine person who presents. A spine fellow who presents is expected to describe findings. It's not expected to describe how he did the examination. Like your start of your examination, again, sorry to say, was very rambling. I examined this patient this way and that way, and I understand. You are not describing to us how you did the examination, because if you describe how you did the examination, it's never going to end. Right? Now, again, even the gait also, the way you describe the gait, I would expect a spine fellow to say that the patient has a normal gait.
Sir,
What
one
is a
question.
normal gait? Yeah, what is a normal gait is a different aspect of it.
Typically, most of us have been brought up in the MS orthopedics or MCH surgery training, and this is typically how that works. I don't know how the DNB works, but
I know. But just what I'm saying.
What?
Exactly. But what I'm saying is that people will not find a fault with you for saying that the patient's gait is normal. Now, let's say that if I am like a picky examiner and I want you to say bipedal, whatever rhythm and all, I'll say, doctor, what is a normal gait? You scored a brownie point for giving him an answer right in his face, right? But if not, you have saved like 15 seconds of your time to describe what really is important in this case, is how I look at it. But I mean, when somebody presents the case to me, I don't stop it. But just because, Harshil has given us the freedom of stopping you every few seconds is what I wanted to say, that, when you are presenting, like imagine you are presenting to Dr. Nene in the clinic that you have a scoliosis patient. How are you going to present? That's what we want you to get to, the management and discussion about the x-rays and MRIs and all. We don't want you to get stuck to the so-called semantics of how an MS presentation is. That is all I wanted to say.
Sir, I would like to come in here. I think whenever examinee is there, he has to be smart enough to actually make sure that where the gate is going to become important. Like in some myelopathy cases, he should explain the gate. But in deformity cases, he can just skip the gate and say normal gate.
Even in deformity cases, you will be surprised how many times the gate is different, especially for the severe scoliosis. They have apparent limb length shortening, pelvic obliquities, and also things get weird in very severe scoliosis as well. But the gist of what I am trying to say is that you want to make your presentation crisp. You as fellows want to learn to speak like Dr. Nene. That should be your aim. It should be impressive. You should not be rambling that अरे क्या बात कर रहा है, कब खत्म करेगा ये, ऐसा नहीं. You should not get that impression. So when you are speaking and if you say confidently that okay, this patient's gait is normal, as looking from the back, this patient has these findings from the back. As looking at the patient in standing position from the back, these are the findings. So that does away with all your description of that I have examined this patient in standing, supine, prone, lateral, all those things. So you're describing findings from the back, how he is looking, how she is looking. So that way you can go faster, more confident in terms of how you describe your findings.
Umesh, have you missed something below the pelvis in this patient? Some negative finding on inspection?
Gluteal asymmetry, we have to mention, sir, but it's not.
What else is more important? How about the attitude of the knees?
On one side, right side, the knee is, the left side knee is extended, sir. Right side knee is a bit flexed.
So how does that affect your in thinking of this deformity? So if one knee was kept in a flexed position, what would that indicate? Here it's controversial. She's wearing loose jeans, etc. All I'm saying is that when you finish your inspection, since you've gone so much in depth, I would have expected you to also comment on the attitude of the knee. And if you have one knee that's flexed, how does that, what does that imply?
Because of but her temple of Venus appears to be at the same level, sir. If
Umesh, the question is very specific.
Yes, sir.
If there's a knee flexion, what is your inference out of it?
There may be if there is knee inflection, apparent limb length discrepancy.
So, how do you proceed? If there was a knee inflection, how would you then take your examination forward?
So we have to do limb length measurements, sir, true and apparent. And if it we have to mask this with by giving some rays and then again examine, sir.
But if the true length was equal,
yes, sir,
you would still want to give a raise.
If the true length is equal, yes, sir, we should still give, sir, for examination.
What will happen if you do that?
What will happen at pelvis?
Pelvis will become symmetrical, sir. Or raise, or pelvis will raise on that side.
So here your PSIS is at the same line, but
yes,
your
sir.
one knee is in flexion, right? So how would you then move forward? Your pelvis is already square, but one knee is in flexion. Does it indicate something to you?
You had already given the answer in the general examination.
Yes. Because there is no, I have examined the limb length, sir. There is no any discrepancy in the length, sir.
What if the scoliosis disappeared on the sitting position?
It's infrapelvic causes of the scoliosis disappears on sitting position.
And what if it disappeared on the lying down position? It stayed on the standing, stayed on the sitting, disappeared on the lying down position.
Now, postural scoliosis, all those disappear on the lying down positions.
Okay. You want to still tell me about the limb length, or we just pass that and move forward?
No, sir.
So basically, the knee, you at least you want to comment about the knee. If the knee is in flexion, that means the child is causing a pseudo correction of the pelvis. The pelvis is actually oblique, and the child is causing a pseudo correction by bending the knee. So yes, by bending the knee, the pelvis drops down on one side, and this child you want to examine in the sitting position to know how much the infrapelvic or the limb length measurement is contributing to the scoliosis and the balance also.
Yes, sir.
Right. Do you know how to examine for fixed pelvic obliquity?
Yes, sir. We should, by squaring the pelvis, we should examine the patient, sir.
How would you square the pelvis?
In adduction deformity, we have to adduct the leg to take
one
it.
Leg or both legs?
Unilateral adduction deformity. No, sir. We have to adduct both sides.
Both the legs.
Yes.
All right. Go ahead.
Inspection from the side. Cervical lordosis is present and thoracic kyphosis well maintained. Lumbar lordosis present. Plumb line falls in line with the greater trochanter. Apologies, sir. I don't have any photos from the front. Head center, but head center on the shoulder. There is no any neck tilt. Prominence of the left side of the chest. Both ASIs are placed at the same level, and no evidence of patch in the front, sir, from front. On palpation.
Hey Umesh, I just one point. Dr.
Yes,
Menon asked you about global balance.
Yes,
you
sir.
are always seeing head centered over the shoulder, but you have to talk
Sacrum.
about head with respect to the pelvis.
Pelvis. Head center over
Head
the
head centered over that shoulder is torticollis or whatever, right? But you have to talk about global balance and truncal balance.
Was it a typo mistake or was it intentional?
So head centered over the pelvis, you want to say. Head centered over the shoulder is fine, but you are describing a thoracic deformity. So
Yes, sir.
don't go too much in the neck. You
Yeah.
don't want to lead the examiner into cervical issues associated with thoracic scoliosis. You want to stick to your thoracic part of it and say head centered over the pelvis, plumb line drop from C7 or occiput or wherever you want to drop the plumb line from falls in the natal cleft. So it's
Yes.
one sentence. You are saying head centered over the pelvis, plumb line drop from C7 falls into the natal cleft. That's it. And then go ahead. So you don't have to come back to this story back again with your plumb line measurements and all those things again. Once you're dealing with one finding, say it at that time and go ahead. Like the same goes for truncal shifts. The truncal shift, how will you measure? The same way, maximum width of the thoracic cage from the apex of the deformity, you fall down, it's going to fall towards the right side. So the same principle applies. But again, because you came back to head centered over the shoulders, I kind of said it again. It should be pelvis.
Yes, sir.
Yeah, carry on, Umesh.
Go ahead.
Sorry. Yes, sir.
Yeah,
I-
Umesh, did you get the way what Shridit mentioned, how to measure the truncal shift?
Yes, sir. We have to measure the truncal width from the center, sir. If it is more shifted on one side, it is imbalance. And we have to see with the plumb line also, sir.
So no, from where will you drop the
Plumb
line for a thoracic decompensation or a truncal decompensation? From where will you drop the plumb line to measure how shifted the patient's chest is with respect to the pelvis? You know what I mean?
Yeah,
If
yes,
you
sir.
can quantify it if you want, but
Isn't that a radiological quantification rather than clinical at this moment?
yeah, it is radiological. You don't have to do it.
Yes, sir.
I mean, I never do it. As fellows, I think you should say what you do in practice, right?
Okay, sir.
But there's one thing that we do in practice which you have missed. So I don't know when it will come in your examination, but I hope it comes.
Sir, on palpation, there is no local rise of temperature, no superficial and deep tenderness. There is no any step of palpable. Thoracic kyphosis well appreciated, and other inspectory findings confirmed, sir. And assessment of deformity, the right shoulder is at a higher level, sir. Right scapula is more prominent and elevated. Right main thoracic scoliosis present with apex probably around T7 to the T or T8, and left thoracolumbar or lumbar and lumbar scoliosis apex most probably around L2, L2 and L3. Right rib hump and left loin hump present, sir, more prominent. It becomes more prominent on Adams forward bending test. The rib hump is more than the loin hump, sir. On scoliometer reading, the plumb line scoliometer reading, the thoracic hump is 31 degrees and lumbar.
Dr. Umesh, before going into the measurements of the deformity, you think
Yes, sir.
she's balanced or imbalanced? Shruti was asking this question to you, and Dr. Menon. You think she's balanced or imbalanced?
Coronally, she is balanced, sir, coronally.
Globally, she's balanced.
Yes, sir.
So essentially, there's no truncal shift.
No truncal
shift because I got
by
the point
definition, I don't think that's correct, because global balance only tells you that the head is centered over the pelvis.
pelvis.
You can still have a trunk shift. In fact, in this child, you will see that in this picture that you've drawn, the balance, the head is probably centered over the natal cleft, but the trunk is substantially shifted onto the right.
Right side.
Yes, sir.
So that's how it often happens. So
Yeah.
So the way to measure it is take the width of the chest wall, like the width of the chest, and then drop a
And
plumb line
measure.
from the middle.
Sure.
Or you can
Yes,
drop
but-
it from the edge of the ear and then drop. So it's
Edge of the
approximate. You can just see it
But that
actually.
has not been described so well clinically as much
Yeah.
as radiologically.
Radiologically, yeah. True measurement is going to be radiological.
Correct.
The other thing is I would prefer that the description is thoracic prominence than a hump. Hump
Okay.
is not like a very standard kind of, you call it a prominence.
Even lumbar prominence
Okay.
also.
Yeah, it's not called hump anywhere.
Yeah, lumbar prominence, thoracic prominence.
Yeah.
You can-
It's an axial trunk rotation, ATR, thoracic axial trunk rotation, or thoracic prominence, or lumbar prominence, rather than calling it hump.
Yes, sir. The plumb line falls within 10 millimeters of the gluteal cleft, sir. To assess flexibility, we have done push prone test, side bendings, and hanging over overhead bar and lifting the child, that we have not done, sir. And in our center, we do awake traction for assessing
No,
flexibility.
you have to present your findings.
Yeah.
Yes, sir.
Each of these things, what you
See,
mentioned, you have to present. You have to tell
Yeah.
what you did here.
In push prone method, we have to ask the patient to lie prone and put one hand on the rib, the thoracic prominence, and other hand on the lumbar convexity, that is lumbar prominence, and give pressure to assess the flexibility of the curve, sir, whether the curve is decreasing in magnitude.
Is your second hand on the lumbar prominence, or is it to stabilize the pelvis?
Yes, sir. It is to stabilize the pelvis.
Arms by the side or arms above the head?
Patient's arm should be on her head, sir.
Above the head. To take away the scapulae, see, to uncover the scapulae, understand the thoracic appendage, and one hand stabilizing the pelvis,
Yes, sir.
or somebody else, and you giving pressure on the apex. And how do you infer that? What do you make out of it?
We have to inspect, sir. The hump is the thoracic prominence is decreasing, and the curve also becoming more straighter.
I think we should proceed. Yeah, let's get to the core here.
So basically, I would like to ask one thing. Do the examinees need to talk about the flexibility with these tests in the exam? I don't think so.
No, you should not. I think you should talk only about what you did.
Yeah. And also what you see. You don't do all these things in your daily clinic, right? So you can go across.
The supine side bending is what we normally do. But if you do the push prone, or if you do a fulcrum bending, or if you do a traction film, that's fine. Just by the way, Umesh, is traction film a routine thing for adolescent idiopathic scoliosis?
A high degree of curvature, if it is there, sir, the side bending won't be possible because of the iliocrystal impingement. In that cases, we should go for the traction X-rays.
So which kind of scoliosis is a traction film mandatory to do?
And scoliosis with a greater magnitude, like more than 80 degrees scoliosis, and neuromuscular scoliosis, we should do a traction X-rays.
So in neuromuscular is one indication.
Yes, sir.
If you have early onset scoliosis, very often a traction film is mandatory because it gives you much better results than a side bending or a fulcrum bending in early onsets. Okay. So let's come back to our results. Yeah.
Survival
radiology
movements.
later, correct?
Yes, sir.
You'll be telling us about the radiology later.
Yes, sir. Radiology is fine. Yeah. The movements of the spines are normal, and examination of hip, knee, and ankle joint is within normal limits. Neurology, essentially the neurology of this patient is normal, sir. With abdominal reflex is also symmetrical.
Why did you do a special mention to abdominal reflex? Any significant?
Yes, sir. Asymmetrical abdominal reflex is a quick test to assess any if there is any presence of any intraspinal anomalies. Like,
Hey, but in the exam, this has to be more detailed. Just because we are short of time, it's going like this. But
cursory. Yeah,
you'll have to
Yeah.
describe the neurological examination like it's like
Properly.
really, really in detail. Like going from sensory examination, the modalities, like every small thing you'll have to say, because
long tracks. The way you do a
it's
milo.
yeah,
Get all the
it
tracks.
can't go that a neurological examination is normal is not what you would be able to get away with, you know. Now it's fine, I guess.
And the foot, and the foot.
But like, you know, if I have to give you a tip which like I used in the exam to make it faster, your presentation, because scoliosis so many things to say, is what I used to do, or what I tell students to do is to combine the inspection and palpation together.
Okay, sir.
You know what I mean? So I would start off the spine examination is that my inspectory and palpatory findings are okay. That way you don't go back and forth with, you know, you're describe the whole thing again, head centered over the pelvis, and then palpation, you're again describing the scoliosis back again. No, so you just combine the inspectory and palpatory findings and then just don't go back to it again. So that way you kind of get the whole picture. You have palpated it, because in reality you are not doing these things in isolation. You are doing inspection and palpation literally together when you are examining the patient, right? So that way you can just present it together by just saying that my inspectory and palpatory findings are, and then go blabber on and don't stop, so that, you know, you don't repeat yourself in your examination. You can go much faster that way.
Right, sir. Yeah. Carry on, Umesh.
My provisional diagnosis is a case of scoliosis with a right main thoracic and lumbar, thoracolumbar curve with a flexible compensated curve in a 16-year-old girl, who is 3 years postmenarchal, with no obvious cause detected on history and clinical examination, presenting mainly for cosmetic concerns without any evidence of neurological neurodeficit and cardiopulmonary compromise, most probably idiopathic scoliosis at this stage of clinical examination.
Gosh.
Will you want to
How
say?
did you actually say that it's a flexible curve? Did you assess in your clinical examination, did you assess flexibility?
Sir, we have done the test to assess flexibility, push-prone test, and so.
And what were your findings on that particular test?
Can you quantify that?
We can't quantify that, sir.
Yeah. So when
it's
you
an
give,
approximation, you know. It's like if the curve is not budging at all, then you can call it rigid, you know.
so
But
why do you want to give in? Don't give in like
it's
this.
difficult.
Flexible curve. Yeah.
Don't comment on the flexibility of the curve at
Yeah.
all.
Don't comment on the flexibility, and you should always stay about the balance. You know, with the occiput centered over sacrum or.
And the onset of the curve, you missed the onset of the curve.
He said the onset 3 years ago. 3 years postmenarchal.
No, patient is 3 years postmenarchal.
And the curve is also 3 years post. And the child noticed the curve 3 years ago. He did say.
No, so you have to say that the onset is adolescent onset curve. No, just say what it is. I mean, what does late onset mean, right? You know, just say it is adolescent onset. It's first notice in adolescent age group.
I don't know.
Also about the progression of the curve, he should mention the progressiveness of the curve also.
Yes.
See, some examiners in MS exams, they insist on such very long diagnosis, which should include the etiology, pathogenesis, a brief summary of the history, and all that kind of nonsense. But I don't think this is required. My own impression is that you should say it's
for a fellow level exam. For a
thoracic and a left lumbar curve.
Yeah, for a fellow level exam, now starts your examination. Now you start your test. You know, after this starts your test. This is okay.
Yeah.
For a fellow level, now starts. Now next slide is where we'll start with the.
This is very orthopedic resident.
This is up to this fine. This PG level. Right now, let's go ahead.
Yeah. What would you like to do as a typical question?
So I would like to investigate with radiological investigation, sir. I would like to get X-ray of the whole spine and PA and lateral position.
Lying down.
But no, sir, standing X-ray.
So let's go. Let's go across. Yeah.
But
PA, you said PA.
yes, sir. But we are in here, sir. In our center we do AP X-rays.
Is there a difference between the two?
Yes, sir. We should usually do a PA X-rays to reduce the
Why?
amount of radiation.
No.
Radiation to?
No.
And
No.
Radiation to what? What is the radiation
most of the
difference between AP and PA?
What you do in your center is correct. So you do AP
Yes, sir.
X-ray. So
AP
tell me why
X-ray.
you do AP X-ray. He's asking a very clear question. Why do you want AP X-ray?
AP X-ray, we the bony structures we should see good in AP X-ray, sir.
Correct. So,
Yes.
but why do you recommend a PA X-ray? Why does the SRS recommend a PA X-ray? You were correct when you said radiation exposure, but radiation exposure to what?
To the most of the patients are adolescent girls. Radiation exposure to the breast and
To the breast, you're absolutely right.
yes,
The
sir.
gonads have exactly the same radiation exposure in AP or PA. It doesn't make any difference. But it's only for the breast and the
Yes, sir.
thyroid that it makes a difference, where the AP gives a
And
larger dosage than the PA.
yes, sir.
But the PA X-rays you would do only for follow-up.
Follow-up. First
So
X-ray
if
is
it's the
AP.
first X-ray you are doing,
It's AP.
you want a
It's
good
AP.
quality X-ray,
Yeah.
right? So you use good quality X-ray with whatever radiation shield for the gonads and whatever the people do it with you. You have breast shields and all if you want first X-rays. First X-rays are usually the standard AP X-rays. Follow-up X-rays, you just want to measure curve angle, then they can be PA views.
Yes.
So tell us about these X-rays.
Okay, sir. Sorry. This is a X-ray of the whole spine, standing view, AP view from the cervical spine up to the proximal femur, showing mild proximal thoracic curve and main thoracic curve and thoracolumbar and lumbar curves.
No. Here there is no mild, major, minor, minimal. Curve, present, absent. So we are talking now you are a fellow, right?
Yes, sir.
So now you're talking. So how would you? So X-ray is clear. First X-ray is AP, follow-up is PA. Right? AP X-ray, we know it's standing. You got full, perfect, well visualized X-rays. Now what do you see in this?
I see two curvatures. The shoulders are the right shoulder is elevated, sir, and there is one main thoracic curvature and one thoracolumbar curve, and the pelvis it appears to be riser 4, and triradiate cartilage is 2 spread.
Before
Yeah.
we start this, we should make sure that our pelvis is squared, right? So first thing you see down, come up. What's the SRS recommendation? More than 2.5 inches of LLD, it has to be corrected.
Yes, sir.
Right. So we first see is the pelvis squared, right? At the same time, in a child, you can look at the TRC and the riser index, right? So TRC, is it applicable here? No. What is the relation of the TRC with menarche and PHV?
So first peak height velocity appears, then the TRC closes, and then the menarche is followed by menarche.
Come again.
I think TRC is before
TRC
is before. First
PHV.
TRC closure, PHV coincides roughly within plus or minus 3 to 6 months, and then is menarche. And how much time it takes to go from reserve 1 to reserve 4 or 5? A standard exam question. How much time does it take for somebody to go from reserve 1 to reserve 4 or 5? And at what stage does menarche come in the reserve index?
Oh, just ask 4, not 5.
Reserve
5
4,
is very
sorry, 4.
variable.
Okay, 4.
1
sorry,
to 4.
4.
Menarche comes after reserve 1, sir. And it takes around 2.5 to 3 years for from reserve 0 to 4.
No. It takes from 12 to 18 months to go from reserve 1 to 4.
2 years approximately.
12 to 18 months, and menarche coincides with 2.
Yes.
No, so also remember that this is very, very, very variable. It's not like that at all. Like in reality, it will correspond to Reaser 2 or Reaser 1 in like 30-40% of the cases only. So this is very, very approximate. Don't take it for the literal truth. Whenever you are describing growth of somebody, it is in relation to the
Multiple
past if you are
factors.
following, or one given point in time you have some approximate idea about it, but in reality is not so rigid mathematics to it, right? But
And
like coming back to the x-ray which you are describing now,
Yes,
like
sir.
have a systematic thought towards describing a scoliosis x-ray.
X-ray.
Like I heard you jumping from the shoulder to the scoliosis to triradiate cartilage to risser. So don't jump around like that from one place to the other. Your primary aim first is to describe the scoliosis. Okay. So you have scoliosis, you have three curves: proximal thoracic, main thoracic, lumbar curve. So you have
Yes.
three regions of it. Then you say that which is your largest curve. Looks like this is the largest curve. This is the apex from this place to this place. And this is the lumbar curve. Apex is L2 from this place to this place. You are not seeing any bony anomalies. You are not seeing any congenital anomalies in the spine, right? And then start going to the periphery, because you won't be able to kind of, the examiner is following your words. He's going from all over the place, from one place to the other. So have something systematic in your mind. Once you have described your scoliosis, the pattern of the scoliosis, that main thoracic is right, lumbar is left, there are no bony anomalies, this is how it is, rotations, lumbar thoracic curve, how rotated, lumbar, how rotated.
Sir, in the coming
Once
slide,
you
I
have done that,
elaborately
No,
described
no,
for
no, no, no,
AP.
no,
yeah.
no,
So
Umesh.
once you
No,
have
Umesh.
done that, then go from top to bottom.
Yes.
Okay, so the examiner is going to ask you to describe the X-ray.
Yes, sir.
So you had the opportunity to see X-ray before because you have made this slide. But what sir is telling is that once X-ray is shown to you, start describing as sir told you right now. So
Yes,
now
sir.
this X-ray is in front of you. Explain the way, the pattern which he told, and again tell us.
So this is the AP standing X-ray of the whole spine, showing three curvatures of the spine: proximal thoracic, main thoracic, and the thoracolumbar and lumbar, with the major curve of
Okay,
main
wait a minute.
thoracic.
It's not thoracolumbar, it's lumbar,
It's lumbar curve, sir.
right?
Yeah.
Because
Yes,
it's
sir.
not
It's lumbar.
thoracolumbar. Apex is lumbar.
And
So
Yes.
do it according to the linking. Yeah, it's
SRS,
lumbar curve.
SRS classification. And what exactly is this difference, Dr. Umesh? When is something called a thoracic curve? When thoracolumbar, when lumbar?
In thoracolumbar curve, the apex of the curvature should be at the D12L1 disc in thoracolumbar. In the lumbar, the apex should be from the L1 to.
So go slow. SRS defines thoracolumbar at the apex at
Yes, sir.
X1, 2, 3. Which are they? At the
At D12 for the thoracolumbar curve, the apex should be at the
D12 body
D12L1.
or
No,
D12 L1
D12L1
disc.
disc. D12L1 disc, sir.
Only L1 disc, not D12 body. So SRS has clearly said this should be very, very clear. When you because your apex could be a disc or could be a body.
Body.
Right?
Yes,
so what does SRS define as, because Lenki has taken the SRS definition. So what is the SRS definition of a thoracolumbar curve?
Yeah, the apex should be at D12 or D12L1 disc or at the L1 base. Yeah.
L1?
At the D12L1 disc. And
no, it's both bodies. At
Bodies.
D12, a disc, and the L1 body. So why you're saying only disc?
That's what I was just trying to see. Be
It
clear
is.
here.
It is body, disc, body.
Yes, sir.
Right.
Yes.
Below that is lumbar. Above that is thoracic.
Yes, sir.
This is just to maintain a little bit consistency in which they are describing it.
So these are three points: 11, 12 disc. Sorry, 12 L1 disc, L1 body,
and D12.
That's
it.
Yes. Also, in this, you should be able to tell us about the end vertebra of each curve.
Yeah, the main thoracic curve, the end vertebra, the proximal end vertebra is at. Sir, can I go to next slide? I have written that.
Okay.
Okay, fine. Go.
So in the right main thoracic curve, the proximal end vertebra is at the T5 level and the distal end vertebra is at the T12 level. And in the left lumbar curve, the proximal end vertebra is at the T12 level and the lower end vertebra is at L4 level. Sir.
What
you
is the
go back to
definition
the-
of an end vertebra, please, Umesh?
The end vertebra is the maximally tilted vertebra into the concavity of the curve.
And one more caveat.
Least rotated.
And least rotated. Most tilted and
Closest
least
to the
rotated.
apex of the curve. Closest to, because there
Yes,
could be two vertebrae that are equally tilted. So the one that's most tilted at the either end of the curve, closest to the apex of the curve.
Yes, sir.
Okay. Go ahead. Also, I didn't hear you mention about the lateral X-ray. Do you think the lateral X-ray is normal?
No, I have mentioned it, sir. Lateral X-ray coming sides.
Okay.
Why did you take a hand X-ray? Oh God. It's a 16-year-old.
Post menarche 16.
Yes.
Now you opened yourself to a volley of questions from Shruti.
Papre, Sanders, you'll get into big trouble with
Sanders staging, what Tanner's grade, you are ending into all this. You put a hand.
You should not reveal only this thing.
Yeah.
Should not get into it.
Just don't get into it. It's pure Pakka theory. So don't ever put this X-ray. Don't.
Never ask. Even ask for an hand X-ray. Have you taken hand X-rays for 16-year-olds? Like 3 years post menarche, the decision making doesn't change. You know, that's why Ranjit is saying don't get into it. You'll get into kind of weird discussion about Sanders.
Yes. And the lateral whole spine X-ray, sir, the thoracic kyphosis measures around 47.4 degrees with a lumbar lordosis of 69.5 degrees.
Was it plan the election view or this view?
Sorry, sir.
Is it in the Statnara view or this view?
No, it is a lateral view, sir. It is a standing lateral view.
Hey, in the exam, you won't be having time to measure the cob. They might ask you to describe cob method, but probably it might not be already measured on the X-ray. The other thing, on your X-ray, I just want to point out that, when you are measuring, you should not choose different end plates. Like the end vertebra of the main thoracic curve is the end vertebra of the lumbar curve. The moment you choose different end plates, your angle changes. Unless those two lines, the red line and the orange line, are perfectly parallel. Otherwise, your measurements are going to change. It's just kind of a pet peeve of mine. So, whenever I see that, I kind of always say that, you want to, get the same, measure it from the same one. Yeah. Don't change the line.
So what's your assessment of the lateral X-ray? Is it a positive balance, negative balance? Can you tell us if the lordosis is normal, kyphosis is normal?
No, sir. The SVA, it is more into a negative balance.
Okay. And is the lumbar lordosis normal?
It is exaggerated lumbar lordosis.
What about the thoracic kyphosis? Is it normal?
Up to 40, it's not normal, sir. It's 47 degrees. Up to it's a 20 to 40 degrees the normal.
So hyperkyphotic, you'd say?
Yes, sir.
And what's your thought process?
Hyperlordotic with normal pelvic incidence and negative balance.
Yes, sir.
And with a pinch of measurement error, when the lateral X-rays, these X-rays, you ask people to measure, they'll measure differently for different times because the accuracy of these lateral measurements, especially getting that T4 end plate, is not easy.
Not easy.
Yeah, you always kind of get weird values in this. So I don't know what to really make out of this, but yeah, it looks quite a negative balance. Although clinically she didn't look like that. But
what about the neck? Is it what you expected?
No, sir, the cervical lordosis is less on the X-rays.
Is that a common finding in AIS patients?
Yes, sir. If they have exaggerated kyphosis.
Hey,
no, sir.
That's totally wrong. Huh?
Yeah.
They never have exaggerated kyphosis, and they always have.
They always have hypokyphosis, but in this case, she has a kyphosis exaggerated. Sir.
Do you think, Dr. Nene, this X-ray might have some stitching error? Look at the
100%.
arms.
100%.
These arms look like really something. There are some weird things going on in the arm.
Yeah. So invariably in an AIS, you would expect a hypokyphotic thoracic spine and a hypolordotic cervical spine.
Yes,
that's
sir.
an expectation.
Yes.
Right? So if your measures are showing differently, then you got to try and work your way around it, because this girl obviously isn't a true kyphotic.
Yeah.
Go ahead.
Okay, what else you'll take? Which all exercises you'll take more?
Standing AP. We would take side bending exercise also, sir, and traction exercise.
Oh, why? Wait a minute.
traction
Wait a minute. You have already decided what you're going to do.
Yeah. Side bending exercise to see which curve is structural, sir.
So you have decided that this is surgical curve.
No, sir, but
so when do you do side bending use?
To assess the flexibility.
You want to know more about this? Want to know more about this before going to flexibility? Or you have made up your mind this is idiopathic?
Are you sure there's no intracord lipoma sitting somewhere?
What I'm saying is that you get bending x-rays done and then do an MRI, and then you find that this patient has a massive Chiari malformation. Then your bending x-rays are, what are you going to do with those bending x-rays? I'm going to refer to neurosurgery. You know what I mean?
Done our MRI, it's within normal limits, sir. So I'm not mentioned here.
No, you can't. You can't jump to that, right? That's what I meant. Most of the time, this is a very common mistake that is made, that you jump to the diagnosis and start going in different direction. But have you decided that this is idiopathic? Because bending x-rays and traction films and all will come when you know what this is, the etiology, the natural history, what is going to happen to this curve if you leave it alone. You have a pretty good idea what would happen if you just keep observing this. For that, you require to know what the etiology of this curve is, right? To know natural history. So at this point in time, are you convinced that you have a fair grasp of the natural history of this curve, and you would go ahead without doing an MRI? That's what the whole point of reasoning will come to. So if you are asked about what you want to do next, what would be your question? What would be your answer? Sorry.
So we would like to go get an MRI to see whether there are any intraspinal anomalies or whether the MRI is normal.
Yeah.
And then proceed for other bending x-rays.
Don't utter that word bending unless you are talking about MRI.
Yeah, don't talk about bendings until you are reached diagnosis.
Okay. So you have
so
MRI.
Do you have anything in this patient's clinical or radiological presentation that makes you think that there's something odd going on?
No, sir. On clinical and examination, no causative factor.
And the radiology?
No, sir.
What are the radiological signs that will kind of point towards a potential non-idiopathic cause? Are there any in this patient?
No, sir.
Which are the ones you will see or in your mind, which you will want to make sure that this might be an atypical curve?
Left thoracic curve, short angular curves, kyphosis at the apex. In these cases, I would think
short
that it is
angular curves.
Left thoracic curve.
Thoracic apex.
Yes,
what is short? What is the definition of
How
short?
many segments?
Short means what?
4 to 5 segments is a short angular curve.
less than 6.
6.
Between the end vertebra, less than 6.
Yes.
And that's in which condition?
Short angular curves are expected in which conditions?
Which condition?
Short angular curves, yes, sir. We expect in neurofibromatosis.
Which type of neurofibromatosis? Which curve?
Neurofibromatosis type 1.
Dystrophic curve in an NF.
Yeah.
NF has two types of curves, non-dystrophic and dystrophic curves. So dystrophic curve in an NF, you expect short angular curves.
Yes.
Even congenital sometimes can be short angular, right? So non-idiopathic. You're right.
Okay.
Yes.
I don't know if this negative balance worries someone. I don't know.
The balance is definitely of concern, but especially when there was no hyperlaxity. There's no hyperlaxity in this child when we examined. Plus, there is significant, negative sagittal balance.
The negative sagittal balance is because of that posture. If you take an X-ray with both the hands on the shoulder, the patient tends to lean back. This is normal. Whereas one of the recommended positions in the SRS for X-rays is you extend the arm forward and hold a bar. They have a transverse bar and you hold on to that and you take a lateral X-ray. In that, you will not get this particular anomaly. And if you look at her clinical photograph, you'll find that she is absolutely well balanced in the lateral view. This is because of putting the hands on the shoulder. If you put the hands on the shoulder and stand, very often people tend to lean backwards.
Yes.
That's a good point. Yeah.
Can I go to next slide, sir?
Yeah.
Yes.
I mean, I think the controversy about getting MRI done or not, I think as a fellow, you should just say that I would get an MRI. Try not to get into that kind of pattern, especially if you are thinking of surgical kind of a solution to the problem.
Yes.
Basically, after this, you will always be asked what other radiological investigation would you like. You should say, I would like to get an MRI, sir, knowing fully well, because the next question is going to be, what is the radiological incidence of MRI anomaly in an AIS? And what is the current data on that? And then it will also go to the red flags for indications for MRI. And then you should have a strong answer as to why you're doing an MRI, even though if there are no red flags in this patient. Okay?
Yes, sir.
That should just vomit out, cut, so then you move on.
So what is the answer?
Rapid progression of curve.
No. What is your reason for doing an MRI, even though you feel that this is a typical idiopathic curve?
Yeah. To see whether the patient is any intraspinal things like tethered cord.
I know. But this is a typical radiographic presentation of AIS. Chances of intraspinal thing are extremally rare, but still you are doing an MRI. What would be your reasoning? Like what Dr. Nene is saying, what would be your reasoning?
The patient,
the incidence is so low.
Yes, sir. The patient is more concerned of the deformity. If we plan a surgery, we need to get MRI to see whether there is any.
So you would have an MRI done only if you plan a surgery, or you are there some times when you have an MRI before?
No, if we plan for conservative management in idiopathic cases, we should not get MRI. There is no evidence for getting MRI.
But there is no evidence. There is a lot of evidence that says that MRIs in idiopathic scoliosis is not always necessary.
It's not always necessary.
So you should know that controversy. So you are still going forward with an MRI in spite of an idiopathic looking curve because you are going to get surgery done. So what would be your answer that you will rattle off, like what Dr. Nene says? That's because this is going to be a standard question. Because you are expected to know that there is a controversy. Some people get MRIs, some people don't get an MRI.
Sir, my
typical idiopathic curve. What is your defense for getting it?
Hello.
Yeah.
So my defense in my exam was always that it's a protocol at our center that we get MRI for all the curves. And I think
you can say that it's a fair, valid thing that my mentors do it, but that doesn't still, it doesn't let the examiner lead to like an impression that you are a thinking person. You don't want to convey to the examiner, you blindly follow whatever has been told to you. There is some thought process to it, right?
True.
So one thing is you getting an MRI done depends on your ability to identify a pattern.
Yes, sir.
Yeah.
Okay. So you can say that, at my stage in my life, I have not seen enough scoliosis to identify an abnormal pattern, or I am not very confident of doing it, because it's still a pattern recognition thing, right? So you can say that, I would want to get an MRI because I'd feel comfortable and there is no radiation involved. So very simple answers you can give, although I don't think it is cost effective and all those things you can say, but literally MRIs are like round the corner at every block right these days. So it's very easily accessible. There's no radiation, and I would feel more comfortable treating this patient surgically if I know in my mind that there is no but still evidence is that it is very low probability, but it still depends on my ability to recognize a pattern. You
And
understand what I
also,
mean?
if you know, there was a study that changed the world order. That initially the incidence of intraspinal anomalies was under 7%, but the study, I think Rajsekharan study, where they did MRIs across the board, and they realized that the incidence actually doubled when you did MRIs randomly. So you should be able to quote that study, because that's what we're looking for. And in the places where where you least expect it, you're likely to get a problem, and that's the reason that I would do an MRI scan.
So there's a Japanese study also which quotes somewhere around 14.7, something like that percentage. So
4% incidence of having to do something for those anomalies. Among the 16.
Okay.
So what next? Let's go ahead.
Yes, sir.
Go to the next slide. Yeah.
So this is the lateral view, sir. That was the lateral view on supine bending film, sir. On the left bending film, the lumbar curve is getting up to 33.9 degrees, sir. And on right bending, the main thoracic curve is getting reduced to 52 degrees, sir.
You don't have the liberty to measure in the exam
Yes,
to
sir.
the accuracy. So what would you say at looking at bending films? What words you'll use?
Looking at the on left bending, the lumbar curve is decreasing, but it is still more than the 25-degree criteria. And the right bending, the main thoracic curve is more than 25 degrees, sir.
Want to mention anything about use the word structural, non-structural curve? Do you want to give anything now here?
Yes, sir. Rotations are seen on.
Effort is a little less.
It is we can see the structural curve on the to structurality can be determined on this bending films.
So I give my argument saying that it's because of costopelvic impingement. This might be a very flexible curve, the lumbar curve. I might be able to pull it out if I give a traction filling. So how can you counter me?
And we are doing supine bending films, sir. So
even supine bending, the ribs will impinge on the iliac crest, right? Or there'll be soft tissue impingement. So the lumbar curve might not really open up well.
But the degree of rotations and this thing is not changing, sir. Not changing much in the bending films also. Rotational anomalies of the vertebra is also not changing much on the bending films, so supine bending films.
So what do you infer out of that?
So there is a structural, this is a structural curve.
So by what are the components of structurality you want to define? 3 things you want to look at it.
The rotational component, the curve should be more than 25 degree on bending films.
Okay. So as per these criteria, what have you made out of all these measurements? What have you made out of all this? Like, you had a main thoracic of 52, you had a lumbar curve of 33, and you mentioned that both of them are structural, and your lateral X-ray gave you 42 degree of thoracic kyphosis and 60 degree or 70 degree of lumbar lordosis, right? If I remember it right?
Yes, sir.
Yeah. So what are you going to do further? What does these measurements tell you?
So based on this supine bending film measurement and on AP and lateral X-ray, we can classify this curve into a lengthy classification, sir. With a major curve being the main thoracic and the minor curve, which is also structural as a lumbar curve.
Okay, so you go ahead and classify.
So it is type 3 lengthy, sir, because this main thoracic curve is more in value than the lumbar curve.
Okay.
Okay.
Only this much is the lengthy classification, or you want to add something more?
You have two more parameters, and
on the sagittal also, sir, it should be the kyphosis.
No. In this, okay, fine. Please go ahead. Sorry. Yeah, sagittal.
On sagittal also, the curve should not
images,
be.
Right? You have the images, right? Why don't you go and see that?
Yes,
go to AP and lateral views. Yeah.
Yeah.
Here the kyphosis is more and the lordosis is also more, sir. Yeah. And on bending films, it is more than 25 degrees.
What parameter does Lenki look at in the lateral X-ray?
Should be around 20 degrees, sir.
What?
On the kyphosis.
What level to what level?
For the thoracic curve, it is from T5 to T12.
There's something called as thoracic sagittal profile or a thoracic modifier. So what is that defined as?
Even before looking at the thoracic modifier, does Lenki say something about thoracolumbar junction?
There should not be any kyphosis at the
how much?
Thoracolumbar.
If you, how much? Lenki classification, when you say 1, 2,
more
3,
than,
4, 5, 6, he
more
tells
than 20 degree. It should not be more than 20 degrees.
Okay, if there is more than 20 degree thoracolumbar kyphosis, what happens? It becomes what curve?
Then it falls into.
When you look at the lateral X-ray, you're looking at two things in the Lenki classification. For the one is the thoracic modifier, second thoracolumbar junction. Like when we look at the AP X-ray, apart from the way Dr. Shritin asked you to read systematically, when you try to make the measurements, you want to try what is the main thoracic, what is the proximal thoracic, what is the main thoracic, what is the lumbar or thoracolumbar, right? You're going to measure the curve. Same way in the lateral X-ray, you're going to look at the thoracic modifier and also the thoracolumbar junction, because thoracolumbar kyphosis more than 20 degree is a indicator of structurality.
Yes,
it is an indicator of structurality. So you have to look at the DL junction
more than
20 degrees. It's an indicator of structurality, right? So that makes it a structural curve. Now you give what a third point which Dr. Harshil was asking you. What the other thing you see in the for the thoracic for the Lenki classification?
Yeah, we should see the coronal modifiers and the sagittal modifiers are also. For coronal modifiers, we draw a central sacral vertical line. If it passes through the between the pedicles, it is.
Have you drawn it in your pictures anywhere? Do you have it in your any of your slides today now? Please show that then.
Yes, sir.
Okay, fine. So
if the CSVL passes between these curves, sir, then We can call it as a
CSVL. So which case is CSVS relevant?
CSV is relevant in the lumbar and thoracolumbar case.
Okay. So what do you see in it, and why do you want to know it? Why did the concept of the CSVL or the modifier A, B, and C come in?
In the apical vertebra, if it passes between the pedicles, it is A.
Apical vertebra of thoracic curve or lumbar curve?
Or the lumbar curve, sir.
Yeah. So why do you want to know that?
To assess the coronal balance in the curve, and to ascertain the stable vertebra, sir.
Okay. So that you can just draw the CSVL. Why don't you know it is A, B, or C? Why did Lenki describe this, and it implies to what? What was it used for? So if it is 2A, you can do this. 2B. See, Lenki classification is essentially it decides your fusion levels. One of the indicator, right? So what did A, B, and C have implication to? You have 10 minutes to go.
B is it should touch the apex of the curve, and C is the CSVL completely medial to the curve, sir.
Yeah, and but what is the inference? What is the significance of that thing?
What's the implication of all this? So what this was described to do something known as STF, right?
So selective thoracic fusion.
Exactly. So will you think of selective thoracic fusion a type 5, type 6 curve?
Type 6 and type 5 we can do, sir.
How can we do? It's a major lumbar curve, right? So it's going to be Lenki C.
Sorry, sir.
So no role of this modifier 5 and 6. So that is out. Then we have 1, 2, 3, 4.
In 1, 2, 3, 4 only we can do STF.
Yeah. In 4 again, by definition, what is 4? All 3 are structural.
Yes, sir.
Right? So do you have any role of this modifier there?
No, sir.
No. So 4, 5, 6 out. Now you have 1, 2, 3, right? In this, you want to decide, can you do a selective thoracic fusion? For that, you have A, B, C.
Yes, sir.
Right? Now, okay, go further, because after that we have what is LTV, what is LSTV, what is SSTV. That's all next. So with this, come on, go ahead with that. So with this, what do you want to know about your modifier? Anyway, thoracic modifier, what was it? Thoracic parameter, N plus or N minus or N?
It is plus, sir, because it is more than 20 degrees.
Okay, so it's N plus.
Yes, sir.
Okay, and what now? What next?
Yeah, we have 10 minutes, sir.
Yeah.
So in our center, we do a traction X-rays also, sir, to assess the flexibility. Based on the traction X-ray also, the main thoracic curve is more in magnitude than the lumbar curve.
Okay.
Then for the management.
So what is the goal of treating scoliosis surgically?
The patient is mainly concerned of this patient is mainly concerned of the cosmetic appearance. So we have to correct the deformity to achieve the spinal balance and cosmetic appearance, and we should fuse the shortest possible. You have to fuse the structural curves and should not give rise to new deformities. So,
so the answer is to fuse the spine with the occiput centered over the sacrum with least amount of fusion segments involved.
Yes, sir.
That is the goal of treatment. To fuse a spine with the occiput centered over the sacrum using least amount of motion segments so that we get maximum movement possible. That is a goal of surgical management of scoliosis, right? Now, how do you decide? Since you have got every parameter pointing towards surgery, your MRI is normal, no ACM, no intraspinal anomalies, no tethered cords, right? No syringes. Now what do you do next? You decide for surgery. What next?
So in this case, both the curves are structural, and then we have to address both the curves. We have to determine the end vertebrae of both the curves, sir. So,
go ahead. I think you already determined the end vertebrae.
Yes, sir.
Now you want to determine the UIV, LIV, right?
Yes, sir.
You already determined the end vertebrae already.
Regarding the UIV, in this patient, the right shoulder is more elevated. So we should stop around D4 level, sir.
You tell about your plan. That's the way to answer an exam. So tell what you would do rather than asking questions.
My plan is to fuse the patient to achieve spinal balance from D4 to
my UIV being D4 and my LIV
being L3, sir. Yeah, because
okay.
Yes.
And show the X-rays first, AP and lateral, and then talk about it. Yeah. Yeah.
Yes, sir.
So tell me, why did you talk about LIV being at L3 and why not L4?
Sir, we don't want to fuse more of the lumbar spine to decrease the spinal motion, and the disc space on traction X-ray is opening well, and it's symmetrical below the L3, L4, below the L3, sir. So we want to end up at L3.
I wouldn't stop at L3. If the numbering is right, I wouldn't stop at L3. The red line is L4, right?
Yes, sir.
The L4, yeah.
So L3 is not a good place to stop on the standing AP. So with respect to which vertebra did you say that this is which modifier curve did you say? ABC? Did you say C modifier or B modifier?
A B modifier, sir, because it is
so
touching the.
With respect to which vertebra did you say it is a B modifier?
What was your apex
number? L1, L2, L3, L4, L5. With respect to which vertebra did you say that this is a B modifier curve? 1, 2, 3, 4, 5. You have only 5 options.
Yeah, it is going through the L4 vertebra, but in our center we perform.
No. There is no. The classification is fixed, right?
Yes.
You can't name it according to what you feel.
It is passing through the L4 vertebra, sir.
What are you talking about? CSVL?
No, CSVL is. You have called it a B vertebra because it is passing through the pedicle of L4 or L3.
No, it is passing through the pedicle of L3, sir. And it is closer to the
so you chose L3 as your apex, right?
Yes,
to
sir.
define the B modifier. Is that correct?
Yes, sir.
Yeah.
If the L3 is the apex of the curve, then your LIV to stop at the apex of your lumbar curve is going to be troublesome, because that also vertebra will have the maximum amount of rotation. Apex technically is the most translated vertebra, but it is also the most rotated vertebra. Okay, so if you stop at L3 as the apex of your lumbar curve, then I'm worried. Basically, I mean, you can get away. I'm not saying you can't get away by stopping at L3, but it's just generally a little against the rule of stopping at the apex, exactly the apex of the lumbar vertebra, which you chose as a vertebra for making this a B modifier curve.
Yeah, L3 has got 2 disadvantages. One is it's the coronal apex. It also happens to be the sagittal apex. So that's
that's true. That's true. I mean, yeah. True.
So, Umesh, give your defenses. Why did you choose L3, 1, 2, 3, 4?
I mean, Umesh, it's just, this is many times it's L3 versus L4 is very controversial. So don't take it in a negative way.
Yeah.
You just think about the reasons why you choose things which way, right? What we are saying is the rationale of, choosing things. And in general, the principle is you don't want to really stop at the apex of your lumbar curve. And you really want to have at least 2 solid purchases below your apex. So whatever your apex is, if you can get 2 anchors below it, you are you are more or less a little safer. So like, say if this L3 is the apex, then you have L3 pedicle and L4 pedicle to control that rotation. You probably are better off. L5 is usually not the LIV in AIS curves, right? It's not a single AIS in whatever the 400, 500 patients in the series have been an LIV as L5. So it's always either L4 or L3 if you are going non-selective.
Yes, sir. So we have done traction X-ray. On traction X-ray, the disc space was symmetrical below L3. So and we were performing the surgery under traction.
Can you show us that?
Yes, sir.
Can you show us that?
Traction view. Can you show traction view?
Okay.
And can I show that other CM images?
L3 is still just
Rotated one.
like now here L2, L3 is the apex, but L3 is still just one below the apex. So it's still a little bit kind of a touch and go kind of a vertebra for an LIV for me at least.
Yeah, you wanted to show something more, Umesh?
Yes.
This is I mean, this is a good curve for non-selective. Sorry, selective.
Selective.
I mean,
Yeah.
This is a good curve for selective. So if the patient is mature, you can correct it less, and you can do selective in this also.
So Umesh, quickly, what are the criteria for selective thoracic fusion?
So
what clinical, what radiologic? There are two things: clinical, radiologic.
The loin hump should not be lumbar prominence. Lumbar prominence should not be more than the thoracic prominence.
Okay.
And the
should not be same or more. It can be same also. If it looks the same as thoracic, then also is a problem. It's not necessarily it has to be more. It should be sufficiently large that you are worried about it.
Yes, carry on. Next point.
One.
And to measure average vertebral translation and rotation also, sir.
Apical.
Apical vertebral translation. Yeah.
Yes. It should be more than 1.2 so that we can go for a selective thoracic fusion.
Okay. Then you talked about AVT, AVR.
Rotation, apical vertebral rotation should not be of the lumbar curve should not be greater than the thoracic curve, sir. And the curve magnitude, curve angle should be less than the thoracic curve.
Okay.
20% capacity of the patient and the surgeon. Surgeon patient both willing for decompensation.
And mature patient.
Mature child.
16
Mature child is no mature child. Restricting capacity of the surgeon and the patient. Lumbar prominence not measured than the thoracic prominence. These are the four clinical criteria: X-ray wise, AVT, AVR, curve angle ratio.
Yes,
sir.
Right? Two things has to be fulfilled.
And flexibility. Flexibility.
Flexible curves.
So your flexibility, thoracic.
And kyphosis also. So kyphosis will add up.
Yeah. So that's the Lenke structural criteria. But in terms of the lumbar curve has to be significantly flexible than the thoracic.
Yeah.
That percentage, it should not be a negative number.
True.
Usually lumbar curves are more flexible because they don't have the ribs attached to it. So most of the time you are going to get, but you will be surprised sometimes the lumbar is stiffer or as stiff as the thoracic, then you are worried.
Yes.
It is a a la carte approach. You have to take it by the curve.
Yeah. I mean, the traction X-ray tells me that your supine bending X-ray is not maximal effort.
Yes.
So your effort, like if the patient, I mean, either it is supervised. So, I usually try to get these supervised because you don't know how much effort this patient is putting. But looks like comparing a traction and supine, maybe the supine is like a little bit less effort, maybe. But There is still a variability in it, but it's potential curve for a selective thoracic fusion as well.
Yes. Sir, any final comments from all the examiners? KV, sir?
Nothing special. Yeah, okay. That's what I wanted to see. What his plan was, and
this was the earlier plan, sir.
Okay.
It was planned up to L4 and hook construct at upper UIB, sir.
I've just seen that plan of yours.
Yes,
when
sir.
you're executing this plan, what would your correction maneuvers be? What is the primary correction maneuver? What are the other correction maneuvers that you would do?
So the primary correction maneuver on the concave side for the major curve will be the derotation of the rod, and on the convex side, it's a cantilever to gain into the.
If that is the case, let me ask you a question. Which is the larger curve, the thoracic or the lumbar?
The thoracic curve is the largest.
If that is the case, you should have more holds on the thoracic curve, on the concave side of the thoracic curve, because that's the primary correcting rod, correct?
Yes,
on
sir.
the concave side of the thoracic curve, you have only 2 holds in the apical region, whereas the lumbar has got 100% screw density on that side. So you seem to be correcting the lumbar curve very aggressively and under correcting the thoracic curve, at least the primary maneuver, which is derotation that you're going to do.
Yes, sir.
Did you understand that?
Yes, sir. Understood.
What you would then get is you would have very good correction of the lumbar curve, but your thoracic curve might remain a little bit under corrected.
Yes, sir.
Okay. And the second maneuver you said is cantilever.
Yes, sir.
Cantilever on the side rod, on the convex sided rod. Would you be doing a DVR? Can you just go back for a second? Would you be doing a DVR on either of the curves?
No, sir.
Any reason? I didn't mean as a primary maneuver. You said there is a significant rib hump and or rib abnormality, and you would want to correct the deformity. It's a cosmetic procedure that the patient is interested in. You would want to correct the rib abnormality as well as the lumbar asymmetry. So DVR would be the most important procedure in my mind.
It was fairly corrected on this thing, both manuals. So
Umesh, we are presenting for an exam.
Yes, sir.
And you don't talk about your case, what you did, but you should answer and give rationale to what you would do for a case.
Yes, sir.
So would you do a DVR when a patient is coming with a primary problem for cosmesis with a significant rib hump?
It's controversial, you know, it's like here and there. Some people like, some people don't. So you should know the controversy. Like, you know, it's plus minus. Some people do it, some people don't. Some people will kind of try to get it like 0 degrees, but you know, you don't have to. It doesn't translate into better SRS outcomes. So it's kind of.
So that brings us, Umesh, do you do any SRS outcome scoring for your patients?
Yes, sir.
What score would you use?
SRS 22F score will use, sir.
22F?
Based on the. Yes, sir.
22F or 22R, did you say?
R.
SRS 22F scoring system should be used.
What is F? I haven't heard of a 22F. Is there a 22?
R. So revised SRS 22R. Yeah, it's good, I think.
Yeah.
Good curve.
So we are already running short of time. I think we'll conclude, sir, with the permission of examiners.
Sure.
Yeah. Umesh, good presentation.
Yes,
and then there's a lot of scope for improvement. And thank you KV sir. Thank you, Ranjit sir. Thank you, Kshitij sir, for contributing to our discussions. This was the second session of the 10 session series. And next session, we are going to have a basic understanding of scoliosis. So we are going to have scoliosis lectures, right from examination, history taking, examination, then investigation, and then planning. We have divided into 3 different groups. So 3 different classes. So we'll be conducting 1 class each session from next session onwards, and there'll be a short case also. And I would really sincerely like to thank you all the examiners for spending 2 hours with us and giving us their valuable feedback and the all the important discussion, because it's going to be significantly helpful for all these exam going students. And any scope for we would like to invite you all again for the upcoming sessions, sir. Thank you.
Thanks. Bye, guys. Good night.
Good night.
Good night, all. Good night. Thank you.
Thank you. Bye.
Thank you, sir.